Co-Chairman Meredith.
Here.
Co-Chairman Meade. Here. Thank you.
Thank you all for your willingness to serve on this task force. As you well know, the Cabinet for Health and Family Services is the largest and most complex cabinet in state government, serving thousands of families throughout our Commonwealth. And the complexity is certainly reflected in the agendas of our committees of health and welfare, Medicaid oversight, child welfare oversight, and our budget review subcommittees. And we never seem to be at a loss for agenda items discussed during those meetings. But please allow me to preface this meeting by stating that the filing of Senate Concurrent Resolution 20 was not meant as a criticism of the performance of the Cabinet, neither past nor present. In fact, we welcome the Cabinet's involvement and participation in this review process. The genesis for this initiative is the testimony we hear in our respective committee meetings, and it is voluminous, numerous, and as well as the hundreds of anecdotal experiences each of us have with our constituents when they talk about their interaction with the cabinets. And I think we have to recognize that each person's perception is their reality, and the public's reality is there's an opportunity for improvement in the way we deliver services to them. And so, again, not meant as criticism, but certainly as an opportunity for improvement in terms of effectiveness, efficiency, and responsiveness to the needs of our constituents. And certainly want to make sure we use every dollar, taxpayer's dollar, to its full ability. To this end, the charge of our task force is to examine the structure, operations, programs, policies, and procedures within the Cabinet of Health and Family Services, determine how services can be delivered more effectively, efficiently, particularly relating to health outcomes, preventing child abuse and neglect, elder abuse, mental health services, assess the current workforce structure of the Cabinet for Health and Family Services with the goal of determining how its workforce is effectively meeting the needs of constituency, evaluate the administrative cost of delivering services and studying alternative ways of reducing administrative cost in the study of productivity of different programs and services administered by the Cabinet for Health and Family Services, and receiving input from the Cabinet officials as well as advocates and recipients of the service and program. And we're going to do all this in 6 meetings. Well, obviously, you know we're not. It's quite a chore that we're undertaking, but again, I commend each of you for willing to participate in this process. But today, our starting point is the review of the organizational structure of the Cabinet. I'm very pleased to have our guests with us. If you gentlemen, you know our routine. If you want to introduce yourself for the record, and feel free to proceed.
Thank you, Senator Meredith. Eric Friedlander, Secretary of the Cabinet for Health and Family Services.
Good afternoon. I'm Eric Lowry. I'm the Executive Director of the Office of Finance and Budget. Thank you for having us.
Yes.
Thanks for being here.
Also sitting is Jackie Richardson, my Chief of Staff for the Cabinet for Health and Family Services.
Welcome.
First, I want to start by saying thank you for the opportunity. The Cabinet is, as you have said, large, complex, perplexing, frustrating, but in the end, what I hope we do is good work on behalf of the citizens and the communities across the Commonwealth. And I want to try to give an overview as quickly as I can around the structure and operations. We have tried to boil this down as far as possible to a couple of slides per department. And so happy to take questions along the way. Otherwise, I'm going to be talking a long time. But please feel free to ask me questions at any point. And of course, we'll potentially leave time at the end of the presentation. Hopefully it's not 7 o'clock. So to begin.
It won't be 7 o'clock. let me interrupt just briefly and say that we have a copy of this organizational chart.
Mm-hmm.
So again, this in itself is kind of overwhelming, but you folks will have a chance to review that in more detail, but I'm sure you're going to cover as many points as you can. But
yes,
just want the committee members to know that this is kind of our starting point. So,
right.
Thanks, sir.
And we have provided a bunch of information, and hopefully this will allow you all to figure out where you want to point within the Cabinet, and with that information that we provide. I'll begin with this and end with this. In any transition, new Cabinet leadership, new administration, whatever, and I've been through a few, what I always suggest folks do is look at our budget narratives, because we supply them to the General Assembly every 2 years. look at what are called the F forms, which are federal fund, talks about federal funds, what they are, what they go to, and then the G forms, which is really kind of the agency fund sort of grants. That's the quickest way. It's still a long way. That's not a small amount of paper, but it's the shortest cut I know.
I'd like to remind our committee members that we had a reorg bill we passed this last time. Nothing on the magnitude that would suggest it was a monumental shift, but it was an important shift. So I hope maybe you can talk about that as well.
I'm planning on that. And this presentation, the reorganization will go into effect on the July 14th. But this presentation kind of incorporates what that reorganization would look like. So without, if it's all right to proceed.
Yes, please proceed.
So we've come up with basically an infographic for each of our departments. This is an infographic for the cabinet. And what we're trying to get across here is that the cabinet's big. That 1 in 3 Kentuckians receive their health care coverage through Medicaid. That we probably touch every life in Kentucky. If you just look at birth and death certificates, right? We essentially have an interaction with every person in the Commonwealth. We also have provided some county sheets. We tried to break down cabinet impact on a county by county basis. Please pull your counties and see, because what we like to talk about, and I'll get into this later in the conversation when we get into the departments, but what does Medicaid mean for a local hospital? What does Medicaid mean for a nursing facility or physicians, right? What does that mean for community infrastructure? Same for grocers, WIC and SNAP, and what does that mean for a local grocer, and what does that mean for support, childcare? What does that mean for that kind of infrastructure? I'm of the opinion, and I believe it's correct, that we, through Medicaid, and again, I'll get this when we get there, a lot of the infrastructure support really comes through some of the programs. And what I hope, if we do it right, and again, that's what we're here to talk about, and that's what we're trying to do, I promise you. If we do it right, it should be supportive to our communities. So I did talk about Medicaid first, because Medicaid's the giant piece of the cabinet, right? You can't talk about the cabinet without talking about Medicaid. And the other reason that the cabinet is structured in the way that it is that Medicaid is able, and I'll show this as we go through the individual departments, Medicaid is structured and the cabinet is structured to basically to maximize federal funds coming into the cabinet and maximize federal funds coming into the state. That is really, I've been there since 1985. That has always been one of the things that the cabinet tries to do. And I'll give you some statistics over the years, and if I forget them, Eric will correct me. But you'll see an agency fund, when we get to different departments, agency funds, if there's a large agency fund proportion in a department, that is oftentimes a lot of that ends up being Medicaid dollars. And I'll point it out when that's not the case. But you can see Medicaid's the lion's share, Department for Community-Based Services, because that's where most of the employees are. That's our eligibility side. Again, I'll cover that a little more later. Is the next largest. It used to be that behavioral health was the third largest department, but because of COVID and the influx of federal funds, that's actually shifted so that public health became the second largest department. I expect in the next couple of years that will shift back again. A lot of that is because behavioral health operates facilities that's really employee intensive. We operate most of our facilities now by a contract, but again, it's an expensive operation. And you can see it goes down from there, but $19 billion. Again, a lot of it, next slide, is federal funds, 72%. And over the years, we have actually the past 4 or 5 years probably shifted out of general fund into some of the restricted funds and our federal funds over the past 7 years, 6, 7 years, we probably increased that about 10% in terms of the federal funding participation, and decreased general fund about 4 or 5%, which I think should be the goal, right? To decrease the reliance of the cabinet on state general funds. And we've been somewhat successful in that. I'd love to take all the credit for it, but that would not be accurate. The public health emergency that extended what is called the FMAP rate, which is the amount the federal government participates in the Medicaid program, that shift probably caused what you see there. That is, I think, whenever that ends, not ended yet. I can't tell you when it's going to end because I don't know. But the longer it goes on, the better off we're all going to be. One other thing I wanted to say here, and this is an important thing to understand from a structural financial perspective. Eric Lowry's a genius, with a G. And he has worked over the years on making sure that we maximize our federal funds. And there is something called the cost allocation system. So the Secretary's office primarily, I know this is a little bit in the weeds, but it's really important to understand. We allocate our costs, like our administrative costs, across all departments. That's really based on number of personnel, so DCBS picks up the bigger part of that. But that's the way kind of the administrative piece is funded. So all of the federal grants, all of the agency funds, some of the general funds are cost allocated across the cabinet. That's why you don't really have a large general fund appropriation to the Secretary's office. So just, I want to give you that because it's really important. That financial structure, that how the cabinet's woven together through that cost allocation system, through really applying costs based on personnel and through how Medicaid comes into the cabinet, that's really an important piece of kind of why the cabinet's structured the way it is and why we're so big. So I just kind of set that as a baseline, and I think it's an important piece to understand.
Yeah, I would just interject that through our indirect cost allocation process, we capture roughly $50 million a year in federal indirect costs. So that goes a long ways towards maximizing federal funds to provide for the administrative resources of the cabinet.
Thanks, Eric. So how do we spend? About 8% on personnel, 1% on operating, and then grants, loans, and benefits. What the heck is that? That really would think of that as payments, primarily payments to providers. That's Medicaid. That's hospitals, nursing facilities, community action agencies, grocers, comprehensive care, local health departments, utilities for the LIHEAP program. That's where this goes. Some of that comes, hospitals, emergency management, and I'll talk a little more about what that looks like and how some of those funds process through the cabinet. But the vast majority, it's contracts, Senator Meredith, as you know. A lot of this is where the funding of the cabinet goes. So 9% is not bad, but that's how the cabinet funds are spent.
Senator Berg.
Thank you, Mr. Chairman. Sir, when we do these contracts, is the price set by Medicaid, or do we set that in the state?
So Medicaid is set. It's a fee that's set. The vast majority of Medicaid providers work within the managed care organization framework. So some of those fees are negotiated through the managed care organization. Oftentimes the managed care organization uses the fee schedule set by Medicaid. They're not required to, frankly, when it's convenient for them to use it, they do, and when it's not, they don't. I think that's the accurate way to say that. Relative to other contracts, the answer is, and it will always depend in the cabinet of, it depends. A lot of contracts are done through request for proposal, where somebody comes back, the bids are scored. That's how the managed care organizations are awarded. But some of, I think, Senator Meredith's other favorites might be Deloitte, and who else would I say that would, raise ire? But what should happen is that gets put out in a request for proposal. Those requests come back in, we score those requests. The other side of that is then to a nonprofit or like a quasi-governmental local health department, comprehensive care center, community action agency. Those are, you can contract more directly with them. That's as fast as I can do it.
Can I follow up, sir?
Yes, please.
Thank you. The one thing in my years of practice, particularly at the Veterans Administration, their contracts were extremely overpriced, much higher than the going community rate, which was very good for the providers who could get those contracts, but actually for the federal government very bad, because we were sometimes paying $2,000 to outsource a procedure we could do for $200. So we're just paying careful attention. That's my only question. We are working on a Medicaid fee schedule and paying careful attention to what we're paying in these contracts.
Yes, and depending upon which provider group you ask, right, we are either barely adequately paying or we are underpaying, right? I'm not picking on anybody, I'm just giving an example. Dentists, right, came to us during the last session and said they were, and we're Kentucky, we don't have good teeth. So how do we properly reimburse dentists for the services that they provide? How do we, do we pay for the things we need to pay for? That is always a conversation. And I think in some ways it depends on who you ask. If you ask in nursing facilities, they're not getting paid enough. If you ask, pretty much everybody we pay tells you that we're not paying enough, okay? But what is that correct rate is always extremely difficult to come up with.
Mr. Lowry, before we move on, I'd appreciate if you would speak again to this indirect cost allocation, because I want to make sure people understand what we're talking about here, because
Yes, sir.
it's something I haven't considered before. Because you said, and please correct me if I'm wrong, that part of the reason the cabinet is as large as it is we have put cost centers under the cabinet, if that's correct, so that we can take advantage of the indirect cost allocation. And I assume when you do that, it's sort of like a cost report in itself. It's step down cost allocation.
Yeah.
Are you using the same kind of methodology or similar methodology that we would use for cost reports for?
Well, somewhat. So we have a federally approved cost allocation plan. And to put it in simple terms, this is so that we can capture indirect cost on these various federal grants. A cabinet as large as ours winds up being expensive when you consider the IT support, the personnel support, the accounting support, the administration in each of these divisions. So for years, there's never been enough money to go around. So we have always looked to maximize our federal funds as much as possible to hopefully help reduce our reliance on the general fund and to be able to maintain a base level of support to all our departments. So with that federal cost allocation plan, it's primarily based on salaries. A statistical analysis is done on what our employees have charged over the course of a month, and we do this monthly, but over a course of a month, what programs have been charged, and then a pro rata allocation is done against those grants, and we are able to capture the indirect costs, which again allows us to further our operations.
And your estimation is that's worth about $50 million?
Yes, sir. For the last few years, and part of it has increased because of COVID. We're certainly aware of that. But for fiscal year 19 through fiscal year 22, we've gone up from 50 to $54 million.
And again, we don't have a preconceived notion of what this task force outcome is going to be. But I know previously that the cabinet was split and with not much success. So that's always on people's horizon to look at that again. But if that were to occur, the possibility exists that some of those personnel, we would lose that reimbursement from the federal government if that were to occur.
Yes, sir.
Okay.
I'm like the secretary. I was around when the cabinets were split, and
You don't look that old.
well, I started fresh out of college. But when I went back as far as 2007 in our current accounting system and looked, one of our metrics we really look at is how many of our general fund dollars are tied to a federal dollar to make sure that we're maximizing our federal funds. Today, and for the last couple of years, we've said at about 86% of our general fund dollars is tied to a federal dollar. In 2007, that was 76%. So we have worked hard through cost allocation and through direct coding to try and maximize our funds as much as possible.
Certainly, that's to be commended, but I appreciate that additional explanation.
I also, I was going to say this to the end, but since we're here, I also lived through the cabinet split and the cabinet being put back together. By the way, it was a Democratic governor that split them and a Republican governor that put them back together. Just, for your information. I wouldn't want to live through it again. It was difficult. It's hard. Speaking as a secretary, it is hard enough to get departments to collaborate and work together. When we were split, it was very, very difficult. And then the cost allocation system, as Eric was talking about, the Cabinet for Families and Children, which had DCBS, really had sufficient at that point, because of the way we did cost allocation, had sufficient administrative funds. The Cabinet for Health Services, which is where I was, so I'm biased, was starved for administrative funds. Because since we did it on salaries, it really split the administrative side to what was called the Cabinet for Families and Children at that time. Two longest serving secretaries in the history of the cabinet survived because I think the cabinet split. But anyway, that's an aside. But it's a very difficult thing to do. It can be done, but it is difficult and hard. So within the secretary's office, so we're still in the secretary's office.
Before you move on, let me allow Senator Alvarado to have a
Just a brief, since we're on the topic, I mean,
Yeah.
as far as, you're saying we went from 77 to 86%. How much would you all estimate we leave on the table? I mean, I know there's a lot of, we've proposed bills that haven't made it through to try to draw down more federal funds, but how high can we get that number to, do you think, if we were maximizing all of our opportunity to draw down federal funds? In other words, how many of our dollars could we tie to federal? Could it get to 90, 92, 95? Or are we pretty much maximized where we're at right now?
We always seem to find someplace else, right? If it took us,
There was a dental bill last year, that's why, that I know
Yeah.
that we're still not, that we filed and we'll be discussing probably tomorrow, it sounds like, but there was an opportunity to draw down almost a 4-to-1 match on that. So I'm just curious, I haven't explored all the opportunities. I'm curious if you all have an idea.
We're always looking. We do have several programs that are 100% state funded. I think of our Frisky Centers, for instance, or our home care program or heart supported living, things that are 100% funded, and maybe we haven't figured out how to match that up to federal dollars, and maybe one day we will. Right now, I think we're bumping up against the current ceiling, but we're always looking to raise that ceiling.
I'll tell you, just as we go through this process, if you know of programs where we could draw more of those, I'd appreciate to know about those, because I think
Yes, sir.
if there's an opportunity for us to find some congruence to draw that, would be helpful. Thank you, Mr. Chairman.
I don't know if it was last Health and Welfare or last MOAC. Sorry. Hospital Association, came,
MOAC.
right? MOAC, and talked about the hospital reimbursement program, where we now have in inpatient, we're up to what is called the average commercial rate, which is great for hospitals. I think it's, we've had a few rural hospital closures, but you just don't see it like you see in other states. And I think that goes a long way towards that. Most of the inpatient beds are in urban centers. Talk with Nancy. What can we do? Are there possibilities to expand? And she talked about outpatient, right? We do inpatient and outpatient with U of L. It's what I've said to a lot of providers, because I think the HRIP program is so good. If you can tell us, or you can provide the agency funds, remember that's what we talked about, if you can provide us the agency funds, I don't know how to put this, you probably won't like the way I say this, but we can reimburse you much better as long as you're not putting it on the general fund dollar, right? So it really is how creative can we be, particularly in Medicaid, with working with our provider communities, particularly those that are in associations and can bring some of that together in agreement, right? Again, I know this is a bad way to say this, but the whole provider tax piece years and years ago was just done to maximize Medicaid. The HRIP program, where the hospitals help us pay, right, for the inpatient, that was an additional $1 billion. You know, it's great. That's good. I think it supports communities. But how we do that and maximize that, I don't know what that limit is. I really don't at this point. But always looking for creative ways to, particularly in Medicaid, because that's where you get 3 or 4 to 1 right out of the box. How do we do that in a way that's sustainable? Is that helpful?
Yeah.
Excuse me. Under the Secretary's office, and then I'm going to get out of the Secretary's office, finally. We have budget, we have legislation, we have information technology, we have our our data analytics group, we have our Inspector General's office. I'm going to pause on the Inspector General's office for a second because they're more external facing than any of these others. All these others are internal, procurement, all of that. It's all mostly internal. And so that was covered kind of what we talked about, the central office piece. But the one piece also that sits in the Secretary's office is the Inspector General's office. And so just to give you an idea, again, this infographic is hopefully helpful. They do all the inspections. Childcare, healthcare, long-term care, all of the different pieces that they do there. But what I hope is helpful, because we had discussion last General Assembly, right? What are we doing about fraud and abuse, right? A very, very good question. So in this infographic, we talk about, what we have put out in terms of recovery from providers, which is where, fraud can occur there, or what is Medicare billing and accurate Medicaid billing, and we can get into all those arguments. But also then our recipient fraud, our investigations group sits in the Inspector General's office. So if somebody calls and says, we think somebody's committing fraud, right, on SNAP or Medicaid or any of our programs, we actually have investigators. Most of them are former law enforcement who will go out and try to track that down. And I just wanted to give you a sense of the scale, about 9,500 calls. We think it's maybe around 5 million that we try to recover from them. And so that's a part of really the Inspector General's office, and I don't quite like it when I say this, really is sort of that enforcement piece. I won't say law enforcement piece, is the enforcement piece, but they do have badges in special investigations. I was very disappointed. I worked for 10 years in the Inspector General's office, and I never got a badge. It made me very sad. But also within SNAP, right? Within the Southeast region, we believe when we look at, this is the universe of the SNAP population. This is not total population, but in the universe of the SNAP population, we believe we lead our Southeast region in folks that we disqualify from SNAP because of intentional program violations. And that can be over income. It can be there's another adult that's in there. It can be, well, all the intentional program violations. They don't report income to us, and we find they had income. We think in terms of taking people off the SNAP roll, we do lead the Southeast region on a per capita SNAP population basis. So I wanted to say that because I don't think I got a chance to articulate that really, and I don't know as I knew that, and they had to coach me on how to exactly say that. So I do want you to know that we take fraud and abuse very seriously, and the main group that does that is the Inspector General's office. DCBS does some of that too. Like I say, if they find it's obvious when they're looking at income that somebody hasn't reported, then we'll do that. So I wanted to, that's where this kind of thing happens, as well as then all our licensure inspections. We are understaffed in the Inspector General's office. I will tell you, we're competing for nurses too. We're competing for inspectors, and it's a challenge to recruit. We are going to try to, within the context of the cabinet, I was speaking with Senator Alvarado earlier today, and I told him, we helped out social workers, and they got every other worker in the cabinet mad at me. So we'll continue to try to work on salaries there as we can within the context of our budget, and we are. And the Inspector General's office is one that we really need to work on, and we're planning on working on. Again, you can sort of see just sort of how the Inspector General is about half, little less than half of what we call our general administration and support. Again, you see the restricted here, quite a bit of it's Medicaid, but this is more cost allocation than Medicaid here. So that's quick on the Inspector General's office. So the giant program is Medicaid. And we've already talked quite a bit about it, so I'll try to go more quickly through this. But as I said, 1.6 million. We think we're going to receive actually in excess of 827 million on the drug rebates. The Senate Bill 50, not this last session, but the previous session, that asked us to go to a single PBM, pharmacy benefits manager. So we pulled pharmacy out of the managed care organizations. We probably within the next month we'll have a nice report. I will tell you, it looks like we saved money. The place we saved money is that we increased the amount of our drug rebates through our pharmacy benefit manager. If you talk to the MCOs, they will tell you that their pharmacy costs went up, and they did, because they don't get the rebate anymore. We do, and so we were able to maximize that rebate. So I think it's going to be a really good news story. It's kind of a preview of coming attractions. But Senate Bill 50, which I think we work very well together on, I think is going to be a net benefit to Medicaid, and I'm actually excited about that. We're hoping that it sets up, because we're the first state in the country to do this. We hope it sets up some other states looking at what we're doing. Actually, our pharmacist in Medicaid is now doing national consulting. That's the price of success.
That is good news, particularly since going back very early on the conversation about the PBM, and it was during a previous cabinet secretary, we talked about going single PBM, and they said it would cost the state millions. We couldn't afford to do that. Of course, their position was supported by the MCOs, and it's obvious as to why. But at that time, we couldn't account for $250 to over $500 million in drug cost. And we thought it was there, and this kind of verifies that. So I appreciate it, but I guess just a word of caution going forward that, we need to make sure when we take a hardline position on something that we know what we're doing, because there was savings when it was projected it would cost us money.
Yes, sir. Yes, sir. And at the same time, we were able to increase the dispensing fee for all pharmacies. I do want to get back to a tiered dispensing fee, but it'll take a year. So that's even with an increased dispensing fee and helping independent pharmacists, right, who came and said that they needed help. And we were able to do that. Now, I feel like maybe we perhaps went too high on that when I saw a name brand chain advertising for Medicaid patients. But
That's a good, good concern there. Senator Alvarado has a.
Just really briefly, I know we talked earlier, 1 in 3 Kentuckians. We've got about, I was looking it up, about 1.022 million kids. 60% of our kids are covered on Medicaid in this state. And I think it's an important statistic for us to remember. We talk about 1 in 3 Kentuckians overall, but 60% of our children are covered by that program. I just think it's important for us to remember that statistic when we talk about that going forward.
And I really, we really need to cover kids. I mean, we just do. And we were able, again, through legislation, through General Assembly, extended pregnant and postpartum women up to a year. We were wanting to do that, got that, you all passed that and instructed us to do it. We were happy to. It's one of those things that we agree on. Hooray! And I think that's very important. And when you look at what's called the CHIP program, that covers children and pregnant women, the number one, and we're working on a Medicaid report for everybody, and we're close. The number one expenditure within the CHIP program are uncomplicated deliveries. So we cover, we think, over half of the deliveries in this state today.
Thank you. Senator Berg, you have a question? Okay. All right, thank you. All right, thank you. Please continue.
The Medicaid budget is all benefits, right? The benefit side in particular, obviously. It is 97% of the budget. That's benefits go to healthcare providers, period. That's where benefits go. Admin, your favorite Senator Meredith Deloitte falls in admin. So, and also all the Medicaid IT pieces fall there. But the benefits piece there that you see is really all going to healthcare providers. What you see in the next pie chart, there are different FMAP rates for different populations in Medicaid. I'm not gonna get it quite right, but the regular Medicaid, mostly what's called age, blind, and disabled. Traditional Medicaid, that's a 70.
It's normally at 72%. With the enhanced FMAP, it's at 78%.
It's a huge difference, gigantic, on the magnitude of almost 50 million a month, as long as that public health emergency is extended. CHIP, K-CHIP, that's 80-20, and expansion's 90-10. So those are the three basic rates. There are some differences now on the waiver side because there's a little bump there, a 10% bump there. But this is close to what the Medicaid rate. It's probably 1% or 2% less if you did blended without the enhanced match.
Secretary, what always confused me about this slide, and this one always gets my attention, is we say administration is 3%, but we know we're giving 10% to the MCO. So is that 3% not inclusive of that?
It is not. The MCOs, I'm going to say something good about them.
You don't have to. You don't have to.
What they were designed to do was give us budget predictability. And if you look back over the years, they have done that, right? That's the largest portion of the Medicaid. I would love to tell you that's not the case, but I looked and it is, right? So got to say that.
Well, that was part of Commissioner Lee's testimony this last session on my MCO bill was it gives predictability, and I certainly think that's certainly valuable to our budgeting process. But I think we also have to recognize the implications of that as well, and sometimes it's adverse. But again, what concerns me is if this 3% is administration within the cabinet, plus 10%, is it plus 10% for the MCOs, and that's 13% for administering this program.
It is.
That's high.
It is plus 10% for the MCOs. The MCOs, the payments to the MCOs are considered to be benefits, by and large. So yes, that's an accurate point.
All right, thank you.
The Department of Community-Based Services, our next biggest program. Again, it's a big program. So this is TANF, childcare, SNAP, in terms of benefits. Also, all the money that goes to community actions agencies flows through community-based services. At one point, when I was with the city of Louisville, I was the community action director there, so I got familiar with those programs. I forgot to say how many places I'd already worked in the cabinet, the inspector general's office and other things. Never worked in DCBS, but did work in community action. And so LIHEAP, again, where does that funding go? It goes to utilities. Where does it's called a water program, I'll just say it that way. That goes to water and sewer across the Commonwealth. So those programs, that's where they go. And so individuals individuals are eligible for the program, and the funding goes to the provider. Same with SNAP, goes to grocers. Childcare goes to childcare. Like, no one gets a specific check. Really, the only place where you can talk about that a little bit is SNAP, where you get a benefits card, right? And to some extent, Dan, if we have some emergency programs under there, where we can help folks with very specific emergencies, it's pretty limited. As of the printing of this slide, which was about a month ago, there were 9,100 children in foster care. We're under 9,000 now. We have seen a steady decline for the past several years in the number of children who are in out-of-home care and in foster care. Some of that is prevention money, which we appreciate. We weren't able to spend it all, and happy to talk with you about that. That's going to come back. We didn't just try to throw it out willy-nilly, but focusing on prevention, right? And the Family First Prevention Act, which Eric could tell you all about. Focusing on that and try to provide additional services to families and support, because really, if you can keep a family together, that's what you want to do. I hate to think about if I were a kid in foster care, and when I was doing homeless services in Louisville, that the kids you saw on the street had usually come through foster care, right? And I can't imagine being 18, right, without any family and trying to negotiate my way around. I can guarantee you I wouldn't have done well. I had enough challenges with a good family. So it's just, I think it is our greatest challenge. I think it is our greatest challenge to try to keep families together during an opioid epidemic, and we'll talk about that later, that goes years, right? We talk about what we've seen in child protective services coming out of COVID is not necessarily more abuse, but what we find is much worse. And I think you could talk to any provider who would tell you the same. It is much worse. So those kids that were in bad situations and didn't have eyes on them for a year, 2 years, it's horrendous. It's just no other way to say it. Those kids that were in either a neutral or a good situation, more time with family has not been bad. I think that's why we're not seeing increasing rates, but we are seeing increasing severity, and that's just true. So offices in 120 counties. We answer the phones. We try to have people go through our Connect website. I will tell you, there were times when we were doing much better answering phones. At one point, we were lucky to answer 100,000 calls a month. We're now answering probably 200,000 a month, but unfortunately, our wait times are back up. And when you get advocates who will come in here and tell you that people wait on the phone a long time, yes, they do. And we are trying to work on getting those wait times down, but it's still a long wait. Now, an hour wait time on the phone versus waiting 4 hours in a waiting room, we think that's better, but it's still frustrating. And I will tell you that there are folks who are still frustrated. I'll give a story, if I may, on DCBS and some of the restructuring in our offices. I was speaking with somebody who we were talking about something else. We were talking about community grocery store, right? And I said, you know, we have the L&N building, which is at 9th and Broadway in Louisville. We have a gigantic waiting room, right? Really well done. Beautifully appointed architecture. The architect brought light in. It's new. It looks great, but it's giant. It's 2 stories of 3/4 of a block long. I was talking. I said, you know, we're trying to go to the phone. We're trying to go to the internet, and the person I was talking to almost started to cry and said, "Thank you for not making me come in and beg for scraps." So we are trying to alter that. We are trying to alter how we interact with the public on eligibility. It's a challenge. It's going to be a challenge, and it will always be a challenge. So,
Well, the numbers you gave us, 100,000 phone calls, an increase to 200,000. Is it presumptuous for me to say that that's COVID aftermath driven?
in some ways, yes, that is true. I would say that that's true. With some additional funding in all the programs, we've actually, in the energy assistance program, started what we're calling a cooling period. So we're extending, it used to be just really mainly the winter for that, what's called LIHEAP, the energy assistance program. We now have a full program that we're running in the summer. All right, today's an indication. I will not win this argument, but I almost think the cooling period is more important than the heating period, and it you know, that's just the way we're going. So we're actually going to use some TANF funds this time to help us complete the summer cooling period. But I think it's just as important. I really do. So yes, there's increased demand. Yes, sir.
Thank you.
I think, yeah, those are the pieces that I wanted to make, and how important prevention is. It is very important. You see, again, the fund splits, general, tobacco restricted. That is a lot of Medicaid funding in that restricted in DCBS. A lot. Cost settlements, services, case management. A lot of this is Medicaid funding. I'd say most of it?
80%.
80%, yeah.
80?
Yeah, 80. So that, just kind of showing how Medicaid runs through, that's how Medicaid runs through. It just shows how it does. And then you can see kind of the splits. Again, the grants, loans, benefits, that's community actions, that's child care, that's child caring, right? The facilities. That's what most of that is there. And then you can just kind of see how it's divided out across programs. Public health, who used to be smaller than this. You asked about the direct impacts of COVID. This is one of them. It increased the size of public health to the point where it overtook behavioral health. And, you know, I'm not going to talk about COVID because we all know COVID. I'm glad we had public health. But, you know, they do lots of things. Their prescription assistance program, I think they presented on that in Northern Kentucky, is a great unheralded program. We need to do more to promote that. I started, actually, again, another place where I worked, I started in public health and certificate of need and state health planning in 1985. I did get out of there quickly. So radon, I think there's some legislation to move some of the radon program to another agency. Fine. And then really what I think folks don't understand a lot about, some of the biggest programs in public health. HANDS program, the home visitation program, really has an impact on abuse and neglect in families. You have a healthcare professional or semi-professional go in and work with parents who are you know, just needing help in basic parenting pieces. First steps, I used to be over first steps. Again, you know, I've been over everything. That's early intervention. It's what's called Part C to Part B. So Part B is IDEA and special education, right? Part C is before kids get to school. So it's birth to 3. and it's services to help the child get back on a developmental pathway that hopefully gets them caught up before they enter school, particularly if they have some developmental or intellectual delays. Great program, serves a lot of kids. Hard to keep in budget often. But it is about, again, it's another one of those things that we should be doing. Done right, like hands, but done right, first step should be about teaching parents how to teach their kid. And they may have a kid with special needs. How do we support them doing that? That's how we should do it.
Well, you know, if there's anything good that came out of COVID, and I know that's a very loose word, but it's raising the stature of our public health. I think before COVID, they were pretty much an afterthought. And quite truthfully, they're predominantly to serve the truly indigent, which I think is a real disservice to those folks. And I think there's an opportunity now to elevate those folks. I think they should be the ones that are responsible for really the health of our entire population, just not the Medicaid, but we need someone who says we're going to improve the health of our population, and these folks could be the driver of that system. So I would hope we've learned from COVID that these folks have a very strong role and really commit some resources to it. And maybe that's one of the things that will come out of this task force is we need to understand how important they are to our communities.
And we talk about the cabinet having a kind of broad umbrella: public health, radiation, restaurant inspections, milk. We say it's from moo to you, so from the farm to the groceries, right? And every step in between. Inspection of septic systems. The state veterinary is there, so investigating rabies outbreaks. I always like to say at 4:30 on a Friday, there's a rabbit bat somewhere, right? So it just happens, and it's a lot of times it's public health, right? But that's because what they do is so broad, and you're absolutely right. The local health departments on the local level, in the counties, the regional health departments, they do a lot for public health and keeping it safe. So thank you for that. One piece, you brought up COVID, and I meant to do this under DCBS. How important do we all know now, how important is childcare? And again, you all passed House Bill 499, which we're working on implementation. It's next year. But where we can work with employers to help support folks getting childcare. The Benefits Cliff Task Force, working through that. The biggest piece of the benefits cliff is childcare. And so that's a great bill. Excited to implement it. And we think it'll make a difference. And again, childcare being important, not just for the folks getting childcare, but for the employers and for the community. And being able to articulate that now that, I think the chamber helped with that bill. Fantastic. And being able to recognize that through this, that's another, I think, kind of benefit of COVID, if you would. I'm hesitant to say that, but I think it is. I think it is. Just like in Medicaid, what we've done with telehealth. We've been needing to do that for 20 years. And we probably are where we should have been 20 years ago today because we had to. And I'm not sure we would have if we didn't have to.
We've passed some pretty good legislation, haven't we?
Yes, sir. So public health's budget, you'll see that the agency funds a little less. So HANDS gets a settlement. Local health departments, there's some back and forth with Medicaid. There's a cost settlements here. So a lot of the restricted fund here, although quite a bit of the restricted fund here are fees, right? Birth certificates, death certificates, frozen food lockers, those kinds of things. So there's a piece of this that's fees, absolutely. But there's also ADAP. ADAP, right. So this restricted piece isn't as heavily dependent on Medicaid as some of the others, but there is a piece of Medicaid in here that supports public health. Again, you can see sort of where their programs go and how they're funded. Laboratory services, I hope next time we can do a capital budget. The lab's old. It's not as old as me, but whatever. We're probably going to need a new lab coming up. It's just antiquated, and you know how fast medical equipment goes out of date. That lab's what, 13, 15 years old at least. So it's just kind of out of date. So that's my plug for next time. So the Department for Behavioral Health, I was acting commissioner there. You're going to hear more about this if you haven't heard. 988, which is a suicide prevention hotline. It's attempting to make it more like 911. I think it gives us some really interesting opportunities. That implementation of Senate Bill 90, how we integrate 911 and 988, I think going to be really critical. We're talking about mobile crisis services. Senate Bill 90 talks about pre-adjudication services to keep people out of going into the jails and trying to provide services, particularly on the substance use and behavioral health side. I think how this marries together, there's so many overlapping pieces on this, but I think this is going to be one of those places where if we do it right, I'm not saying it's going to be simple at all, but if we do it right, we should be able to bring some of these services together. How do we support law enforcement, right, when they're responding to a behavioral health or a substance use crisis, right? We do CIT training, which is that kind of behavioral health training for officers who come through a program, but that's asking a lot. It's asking a lot. So within behavioral health, we have facilities, which we don't really talk about here. I'll show you on the next slide where I think we should be a little more balanced. But also your core program, your substance use program, flows through behavioral health. Now, we've seen a overdose spike, right? Again, that's one of the negatives of COVID, right? Your isolation and economic uncertainty. I mean, that's a perfect storm for folks to relapse, and we've seen it. Also, fentanyl. If Van Ingram were sitting here, he would tell you that the increase in use or fentanyl in the supply chain has had a significant impact on overdoses across the state. But the local communities, there's so many initiatives here I can't even begin to cover. It's called Healing Communities. There's a couple of phases of that. The Attorney General funding, I sit on that task force. I think our first meeting is on the 12th. So look forward to that, because we've got to get our hands around this some way. It is tearing families apart. It's ruining lives. I doubt there's anybody even in this room that doesn't know somebody that hasn't been impacted by substance use, right? Or has a child, or had a child, or knows somebody who's had a child. That's how rampant it is across the Commonwealth. So we've got a lot of work to do. There's just no way around that. The behavioral health program also supports folks with developmental and intellectual disabilities. This behavioral health and Dale, I'll get to them, Department of Aging and Independent Living, we really went out and aggressively got folks vaccines in people's arms who had developmental and intellectual disabilities, who were probably most vulnerable to COVID, even if they were in some of the small, what are called supports for community living homes. I think we did a credible job there. Lots of workforce initiatives. We don't have enough behavioral health professionals in this state. We need to work on that. That a crisis. I won't say it's as acute as the nursing crisis, but it's awfully close. We just don't have enough providers in the state to meet the behavioral health needs. Coming out of COVID, tremendous behavioral health needs. In Western Kentucky, right, folks, when I was down there, folks were telling me, we hear a thunderstorm roll through, and I've got anxiety, right? So we've got a lot of work to do there, and hopefully there's some more funding coming from the federal government, and we'll do the best we can to make sure that we have as much as we can put in community as possible. You'll see residential. That means Outwood, Oakwood are 3 psychiatric hospitals for, if you count ARH, our 2 nursing facilities. Our facilities take up over half behavioral health budget. We should be completely rebalanced in this. it's difficult. These facilities sit in communities. So many secretaries have washed up on the shores of, this facility or that facility. I'm not saying that, but we have to think about what we need in our communities, and what's needed in our communities. And I think as much money as we can push to community supports to keep people in their local communities and in their homes, the better off we're all going to be. Restricted funds here. That is Medicaid. Probably 90% of that's Medicaid, if it's not all Medicaid. So that's, again, what funds the Behavioral Health Department. In a lot of ways, that's a chunk that's funded through Medicaid. Again, just kind of illustrating how Medicaid rolls through the entire cabinet. So Department of Aging and Independent Living, next one. Meals, senior meals. Our state programs, it's called the Personal Care Assistance Program. You all might have heard of the Heart Supported Living Program. A lot of those state-funded programs where folks really don't want to become eligible for Medicaid or may not be eligible for Medicaid but still need services because they have disabilities, significant disabilities. Those programs run through the the Department for Aging and Independent Living. We just, again, legislation from not this one, but the last one, we started our Office of Alzheimer's. It had been on the books, but nobody had actually put it together. Legislation came through the last session, and we now have an Office of Alzheimer's. We've needed it. We're a rapidly aging population. We're going to see, as we age, it's just more Alzheimer's, more dementia, that is what we are going to see. So we're aggressively trying to find grants for that department to build it out a little bit. But that's a piece that we're implementing within aging and independent living. Senior meals, we provided more meals last year than we'd ever had. Again, kudos to community partners, what are called AAAs. They sit with the area development district offices, and they provide a lot of services for seniors in local communities, and they do a good job. We have what's called a aging disability resource, and it's just a one-stop shop. Like, even if you have a question about Medicare, you can call up Dale and get some answers. There are folks, it's called the SHIPS program, and there are folks who are there to help. Aging and Independent Living has, I'll do it in the next slide. You'll see there's this tiny slice of agency and Aging and Independent Living. That's because we were able to, actually we started the previous administration, access Medicaid for guardianship. So guardianship is at Aging and Independent Living. Those people who can't care for themselves and are court-ordered into guardianship, that sits at Aging and Independent Living. So the piece of that you can account to healthcare, right? Coordinating visits and all those kinds of things, and supporting an individual to live to live in community. That little slice is the beginning of accessing Medicaid funds for this program, and are able to get more folks in guardianship hired as guardians, right? Because of that. 3 million?
Yes.
That's an additional 3 million within the program. So that's why that slice is small, but that's why that slice is there. The two most fun programs in the cabinet?
Excuse me.
Yes.
Senator
Oh, I'm sorry.
Berg has a question.
I'm sorry.
Thank you, sir. This is rather trivial. Why is student drug prevention education under aging and independent living? This whole top line of student academic performance, student improved academic engagement, how does that fall under aging and independent living?
Oh, this is under Serve Kentucky. So
Okay,
this
I
is,
got
this
two
is vol-
things.
Yeah.
Okay.
Yes.
Thank
We're-
you.
we're-
Thank you.
Yeah.
Okay.
So as two of my favorite programs, Serve Kentucky and Frisky. I was over Frisky for a little bit. The Serve Kentucky is volunteerism, AmeriCorps. Think of it as Joe Bringardner's not going to like me for saying it this way, but think of it as Peace Corps within the United States. So really serving communities, folks who get a stipend to do a lot of work. These folks do great work. They'll respond to emergencies. They work in schools, right? They work to like this top line. They work with students in schools. They're not Teach Kentucky, but they're Teach America. But it's that kind of concept where folks are actually working. It's called our Frisky Corps. It's how these two programs get tied together. So the folks who can work in family resource centers, who then help the family resource centers help students in schools. And so this kind of thing that they do, and they get folks they sponsor volunteerism across the state. Senator Alvarado and I were talking about some of the difficulties in finding some volunteers. Now it's more in specific areas, but this is a group that helps us with that. And they do a really good job and bring more programs into Kentucky. Joe Bringardner, who served through 3 administrations now in this position, has really done a great job of increasing the size of the program, increasing the numbers of programs we have in the state. And so that's why you see some of the value that you see here. These infographics, we were going by department, so we hadn't gotten to family resource centers yet, but I wanted to slide on them because I used to be over them. They do, I know you all know this, and I know I don't have to sell it, but the concept of removing non-academic barriers to learning was probably one of the best things that came out of KIRA in 1990, and yes, I was here. Having somebody who's really concerned with what that looks like in schools, and I can tell you, during the pandemic, they were delivering food and supplies to folks who were not able to be in school. Tornado, the Western Kentucky tornado, some of those centers really work with getting supplies out. We had a couple of really nice collaborations with folks that wanted to help us. The Shabbat Center, who they get like returns from Amazon, and they help spread that out to the family resource centers. And we're working on expanding that program. But they do so many things. And the thing that I love about family resource centers is they're designed to respond to local needs. They have to have a plan that's locally driven, that responds to the needs on the ground within certain parameters, and that's what they do. And so they fit within the schools and the systems. Sometimes you get into arguments. Principals rule the school, in case you didn't know. But they've learned and adapted, and I think they do an amazing job in schools across the Commonwealth. Was happy to be there early. You can see this is one that it's all general and a little bit of federal. There's no Medicaid here because we haven't figured out how. And I think it'd be very difficult. And if you're locally driven, I think that goes against the concept of what these programs are. Melissa Goins, who's fantastic, also served across 3 different administrations. She likes that I'm the secretary because I know that I can't say to her, family resource centers will do this. Because family resource centers have to want to do it, right? And so we can say, here are opportunities for you to participate in, but the GEAR program, the education piece that came through through COVID, that they had to apply to get that money. They had to want it. And it wasn't like we said, you're going to do this for this. That's not how this program works. This is the best example of a local program and local solutions that they design, and then we help fund. If you think I'm an apostle, I am. I think this is a fantastic program. At Department of Income Support, I was acting here too. These 2 programs, child support enforcement, which is, that's kind of the enforcement side of when somebody owes child support. This is the group that goes out and enforces that. They have an antiquated system. Thank you for a capital improvement piece here. The child support enforcement system is the back end of the unemployment system. It's blue screen, it's old, it's mainframe, I think it's COBOL or something like that.
I believe so.
So I mean, it's as old as I am. It's terrible. Within the capital budget this time, there's funding for a replacement system. Thank you, long needed, and we think we'll be able to do more in terms of helping families get child support. That's what we should be doing. Disability determinations. This is an odd program, so that's kind of why these two programs are together, because they're like the last two, they're just kind of don't know where they fit. Sorry, Commissioner Vino. But disability determination is, we're a contractor to Social Security. So we're contractors for them. So we do all the work of determining whether somebody is determined disabled and gets Social Security disability payments. That's what this group does. I will tell you, because I think so, that they do a really good job here. We've had some challenges. You all know that. Eastern Kentucky, unscrupulous attorneys and physicians working, some physicians working together, right? And it's kind of like pain clinics, right? There's unscrupulous everywhere. That was caught, but it's had its negative impact. There's just no way to gloss over that. It has. And I think part of that has had to do with some of the problems we've seen across the state. I think legitimate folks who need this, they need it. They really need it. But there are redeterminations that are done. I can't, so it's just, these two programs sit there. Again, you will see a little bit of restricted fund. I don't think that's Medicaid. Yeah, I don't think any of that's Medicaid. You see most of that goes to child support. Disability is like all federal funds, essentially, almost all. I'm getting close to the end, I promise.
Before you
Yes.
continue, Representative Meade has a question, comment.
Thank you, Mr. Chairman. Mr. Secretary, I think you made the statement that 56% of child support was collected. Is that what you said?
Oh, no, no, 56% of the budget for this agency is child support.
I got you.
I don't think I can give you a figure other than the $332 million that's been collected through this program. This program's administered on the county level by county attorneys and through their offices. Again, most have been fantastic. I think there's some high-profile cases of where this hasn't worked terribly well, but it's like every other program. There are places where it works great, and there are always, there's one or two that don't work out well.
Is there a way to get some of those numbers
Yes, sir.
that tells us the percentage of collection opposed to what is uncollected
Yes, sir.
each year, and then the amount and maybe those areas where it across the state that it could be collected?
Certainly. I think we can break that, I hope, we can break that down by county for you.
Okay. Thank you.
One of my favorites, I was Commission for Office of Children with Special Health Care Needs. I was the director there for about 7 or 8 years, so it's a place close to my heart. The thing that is not understood about this organization, and I think it is the best thing they do, newborn hearing screening. Newborns with hearing issues, like the number one disability in the country and in the state. Every child that is born gets a hearing screening. The commission follows up. Now, there are always some that are lost to follow-up, but when you look at other states, we do really well on that measure of making sure that we get kids who are not lost to follow-up, if they fail that initial hearing screening, to get them into an audiology booth and try to locate where that hearing disability is. We have 55,000 children born in the state. We do 49,000 screenings through the commission. That tells you do a pretty good job there. Now that's over a couple of years, so I just caveat that. And then some of the specialty clinics. These are kids. I'm going to talk about 500 kids, right? Craniofacial anomaly. These are kids that are probably going to have cleft lip and palate, skulls that aren't completely formed, all sorts of different things. These are kids that are probably by the time they're 18 are going to have 20 surgeries. And this is plastics, it's dental, it's ENT, it's a whole bunch of different specialists that have to come around. It's feeding specialists, it's a lot of different folks. The transformation, that was my favorite day, when we would review the pictures of like, here's a kid that came to us and here's a kid that's 18, right? Anyway, I think it's amazing. Neurology, always very difficult to get pediatric neurology. We in a lot of these areas, we are collaborating with the University of Louisville and University of Kentucky primarily because that's where the medical schools are. And so that's the collaboration that occurs. Also within the commission, they have what's called a family-to-family program. Again, you wouldn't think of this as but it's where parents who have kids with similar medical conditions can link together and support each other. We can do more of that, but I think it's an important service for folks. When I was there, we have a youth advisory council, and we had a parent advisory council, and we actually had a parent on each one of our interviews. There are kind of opportunities that you can do there because it's not a gigantic agency within the cabinet, even though it's about
Before you move on, I think
Yes,
Senator
sir.
Alvarado has a comment or question.
Waiting till the end.
Okay, thank you. Representative Meade, do you have anything else? Okay, thank you. Please
Yeah.
continue.
And just, again, the age restricted fund here, that's Medicaid, almost all. Very little sliver might be what they collect for hearing aids. But this again, just kind of giving you the examples of how everything kind of is financially tied. With that, you heard me talk about how the federal funds flow. I really do believe that our goal should be how do we support communities, individuals and communities. But I think we undersell what we do in community. I think talked about my experience with the cabinet split, where I think you can find the best documentation, and then. Yeah, I think that covers what I want to cover. I'm sorry I took so long, but I don't know how to do it shorter.
You did an excellent job. We appreciate you being here, and I think this is a good start for us. But we will open up for questions and comments. So, Senator Alvarado.
Thank you, Mr. Chairman. And just when you talked about the volunteers, I guess I never had, you learn something new all the time. I didn't realize that we had a department. I always just thought Friskies was its own department, but it's that and volunteer services.
Yes.
And we've had a discussion just recently about the Ombudsman Office and how that's structured. And I've spoken to some of the Ombudsman agencies and their struggle with getting volunteers. Mm-hmm. Have we thought about, I know that's kind of under OIG a bit, and I know they're kind of a quasi-federal requirement. Yeah. We don't have any oversight over them. But has there been any thought about consolidating different organizations that require volunteers to do those and place them underneath that volunteer services? Because some of these folks might be able, if they're wanting to volunteer and they're willing to volunteer, which is the tough part, can they not provide services across various different aspects of under the same department? Because I never had realized that they were underneath that department specifically. So maybe just a thought is if we have some that are struggling to find them. I know the Ombudsman agencies, I've talked to them, they're asking for more responsibility. They want to provide more oversight, yet at the same time say, we don't have enough people to provide the oversight we have now. So would that be a concept? I don't know if it would, we've always kind of done a traditional structure of where they belong, but maybe we can consolidate a lot of those underneath that tag.
I actually think that that's an interesting point and worthy of pursuit, because within that, when I was at Louisville at what was called Resilience and Community Services, my favorite title, Chief Resilience Officer, was great. But we had a volunteerism program. It was called Retired Senior RSVP, Retired Senior Volunteer Program. And those folks would sit at front desks, or they would sit in schools and act kind of as a grandparent to a child in the school. So there are some senior pieces that reside there as well.
Just a thought. Thank you, Mr. Chairman.
Any questions, comments? Yes, please.
Thank you, Chairman. Secretary, first, thank you for your great presentation. It was lengthy but well needed. And thank you for your years of service. I had no idea that you have been in pretty much all the things, so I think that we should be listening to your expertise. I do have one question. I think I may have just missed it. In the public health piece, as far as the budget part, under program, it says that public health protection and safety is 7%. Can you talk a little bit what is in that? And I can't remember if you did and I dismissed that piece.
Yeah, I'm trying to remember too. Hang on. There's labs, there's MCH, there's epi, prevention. So that's got to be.
Is that some of the inspectors?
That's probably the inspectors. So that's probably the milk inspection branch, the radiation inspection branch. There's a lead paint group that's there. That's got to be well, the restaurant inspections I bet are under general health, maybe under general health. But yeah, restaurant inspections, that probably is environmental. That does look right. So
And-
it's the folks that do those inspections.
Okay.
If I am wrong,
Yeah.
I will
Okay.
send that back. But yeah, I think that looks like the right percentage for that.
Mm-hmm.
So it also then, but I'll bet it's more aligned with milk, radiation,
Pools, swimming pools.
swimming pools.
Gotcha.
Yeah. So there's
Okay.
all that kind of stuff that they inspect, and so I think that's where that is.
Okay. Awesome. Thank you.
Let me ask you a couple of questions, if I may. Senator Berger, go ahead and feel free to go first. No, please. Okay, thank you. Great presentation today. Great introduction to this. I sincerely appreciate it. Obviously, we're going to have a lot of focus, I think, on Medicaid because it's such a big part of the budget. And one of the things that's always concerned me, as well as I know Senator Alvarado, is we're not moving the needle in terms of improving the health of our population. We're spending a lot of money, and that's great, and certainly want to maximize all the federal match that we possibly can. But if we're not spending those dollars to improve the health of our population, what have we gained? And to that end, does the cabinet have a mission statement?
Yes.
Does each division have a mission statement?
Yes.
Could you share those with us? I'd like to see what those
Absolutely.
are, because
Happy to send them. Yes, sir.
it's a lot like just hearing the presentation. And this isn't criticism, but we could say one of our goals is to increase our federal dollars. Yeah, we want to do that, but if we're not moving the needle, then we haven't been successful in our efforts. But I think particularly for not improving the health of the population, the amount of child abuse in this state as compared to the rest of the nation, it's got to be alarming to us. And just what metrics of success do we have to know that we're doing what we need to be doing?
I can paraphrase it because I'm embarrassed that I'm not going to be able to say it just like that. But the paraphrase is this. We believe in the cabinet that what we should be doing is helping all individuals and all communities that we work with to live to their full potential. Individuals to their full human potential, communities to their full potential. That's what we should be doing. We do that through what we call different lenses. We do look at equity, right? You've got to. You see differences between urban and rural. We see racial differences in terms of outcomes. We see it. We should figure out how to address it. I told you I was chief of resilience for the city of Louisville. So our second, what I call pillar, is our resilience pillar. But that's the stalking horse for trauma. You don't lead with a negative pillar, right? But but the thread that runs through so many of the families that we serve and individuals that we serve is just direct, straight up trauma. We picked that before COVID, but I'm glad we picked it. And the other piece of that relates to the folks who are on the front line, social workers in particular. When I left the cabinet several years ago, my deepest regret was that we didn't do enough to address what's called secondary trauma. You see trauma all the time. Law enforcement sees it too, right? You're always like entering somebody's life at the worst possible time. And if you don't address secondary trauma, you get horrible outcomes, both for the individual worker and for the folks they're trying to assist. You have to do that. That's our second pillar. Our third one is, you'd be surprised, is economic support, because I think we have never talked enough about what we do to support our local communities. Local pharmacists, local physicians, nursing facilities, hospitals, childcare, we just don't talk about that enough. It's a giant cabinet. It's a $19 billion cabinet. We do support our communities. We do support our counties. I would venture to say that supporting that network and infrastructure helps our communities. And then, of course, how can you do what the cabinet's supposed to do, which is health and wellness, if you don't get those other three right? And so that's kind of how we talk about what those visions are. And of course, then the ubiquitous operational excellence, you can't do it if you're not doing it well, right? So those are the lenses that we use when we talk about mission, and every department does some of that.
Well, I think one of the epiphanies that we're going to have, I've heard you say it several times today, and other cabinets as well, is, we need to do this, but the funding's not there. But we never stopped to identify the cost of doing nothing, which is substantially more than the cost of doing something. Mm-hmm. And we have to have a shift in our thinking there. And I guess I'd like to see every cabinet be more aggressive and say, we need to do this, and here's the savings that's going to result from it. And we don't do that, so they just sit there. You may mention one that 20 years, we knew it was there, we need to do something. Well, why didn't we? Because we don't have the money. We do have the money.
Yes.
And I think when we look at the Medicaid budget, we're still too focused on treating sick people. We know that 60-70% of the healthcare problems are based on social determinants. Why aren't we addressing those? We don't have any money. We do have money. Now, this time we got $15 billion, so we had the money. And maybe that's another fundamental shift I think we're going to have is how we're going to use these funds. And I don't think it's going to be to anybody's detriment if we focus more on those social determinants than we do instead of taking care of sick people. Yeah. So that's a shift in thinking I think we need to have. Mm-hmm.
It is something that I've tried to work on within the cabinet, because that's always the answer. Mm-hmm. We don't ask any secretary anytime, any question, and the secretary's answer to you is going to be, we don't have the money, right? Mm-hmm. Well, what's the program that we want? Let's figure out how to fund it, right? Let's figure it out. But don't say, we can't. But that is such a shift in thinking. It really is. Even in a $19 billion cabinet, it is a tremendous shift in thinking. And it is something that we're trying to do, right? Don't tell me we can't. Tell me how we can.
Well, I think another problem we have is it takes a lot of courage to do that. I recognize that, particularly in a governmental entity. And another thing that's missing from state government is we never want to recognize return on investment. If you come to me and say we're going to start this program and it's going to cost this, but we're going to get this kind of return on investment, and we actually track that and do it, kudos to you. But we don't have enough of that within our system, and I think it's caused us a problem. I think another thing we have to really understand is the relationship between all these things that we're doing. The common denominator is poverty. Mm-hmm. And we never had a centralized, united policy on how we're going to address poverty, and that's urban and that is rural, and it's time to stop that. But Senator Berg, I knew you had something. I just knew it.
As a follow-up, sir, if you would indulge me, some of what you're talking about as far as determinants and the outcomes of care, I am sure are completely outside of your purview to affect. So what I would like to ask is, when we come back together at some point in the future, if you had three wishes that you think could significantly impact the care, the quality of care, and outcomes for people in the state, that require legislation, that require us to do something to support you, what would that be? I mean, I know from my own personal experiences, I'd be getting guns off the street because I deal with 3 gunshot wounds a day. That's costing our state thousands and thousands and thousands and thousands of dollars weekly. Things that are realistic, things that you really think in your dreams, we got the right bills together. What could we do? I'm not saying spend too much time on it because chances of it coming to fruition are not good, but I personally would like to know what that would be.
You know, it's when I worked under the Fletcher administration in an appointed position, and when I was interviewing, right, everybody got interviewed, and I was at Health Services at that point, had been put back together, and somebody asked me, what do you think the most important thing is for government, for us to do here? What is the most important thing we can do? And my answer was education. That's the first answer. The second answer is wages and living wage jobs. That's the second answer. And the third answer, all of these things conveniently outside of my control, by the way, is housing, right? It's so difficult to get people services until you get them into stable housing. So probably not the answer you expected, but if there were 3 things, those are the 3 things I'd look at. I think they are for lifespan, right? For service provision, for making a difference in healthcare. There's nothing like that. And the family you're born into, the zip code you're born into, the county you're born into, shouldn't have the impact it has on people's lifespan that it does. It just shouldn't.
Starting point is obviously this task force. Again, part of this mission and this potential reorganization is how we can use our dollars most efficiently, effectively, and I think there's some opportunities we've identified today. But to that end, if there's any function of the cabinet which any of our committee members would specifically like to look into in more depth, please let myself know or Representative Meade, and we'll try to have that in the future agenda. But I think it's a great first start. Our next committee meeting is Tuesday, July 19th at 3:00 p.m. and we will try to keep these meetings to an hour and a half. I promise you we'll never go beyond 2 hours, but just like to reserve the right to say that we may extend that sometime. But a good first meeting, and appreciate both of you being here today, and look forward to working with you as we move forward. If there are no other questions, comments, then this meeting will stand adjourned.